Dear friends, as you know, the science is evolving. The treatments, they are evolving. There is dynamicity. Whatsoever we are doing today, we try to improvise. Whatsoever we are doing today, yesterday we were thinking of that. Today we are doing, and tomorrow we'll do much better. A term, dynamic correction with functional feedback. What is this? Most of us who are Ilizarov surgeon are gradually correcting persons, doctors, orthopedic surgeons, they know it and they are practicing it. And I will try to simplify whatsoever I am saying by my slides, which will be coming one by one. The deformities, they can be resolved by acute corrections. The deformities can be resolved by gradual corrections, as well as acute correction with rest of the deformity by gradual correction. Those deformities which can be corrected with the help of gradual correction or which have been solved partially by acute and then gradual correction, these are the deformities in which this term dynamic correction with functional feedback. With a simple example, I'll try to show you what I mean to. I will try to simplify this new term. And let's take the example of a 21-year-old boy who's commando in police and he sustained fracture of the right leg 10 months back after a fall. And it was successfully treated conservatively with the help of a plaster. We are talking about right side, right leg, right tibia. Bone union is very good. And he consulted a few doctors who advised, after seeing x-rays, which showed very good union, that he will soon be almost better, almost to the previous level of function. It will take some time to adjust. Nothing active intervention is needed except physiotherapy, wait, and watch. Again, if you want to see this patient, 21-year-old boy with treated fracture of the tibia, and this is his gait. My question is, should surgical intervention be done or it should not be done? Should we go ahead with some sort of corrections or we should not? Please think about this time and again. Might be take 1 or 2 days seeing these x-rays and then make up your mind. And after 1 or 2 days, please come again and see, is it the same which I am thinking and you are thinking, or it is slightly different? Going ahead, after 2 days, once you again and again think what should be done or should not be done, should we wait or should we not wait? Before the injury, he could walk and run 20 kilometers per day. And after 10 months of injury, he could walk and run for about 6 kilometers. And there is limping, as he says. Patient doesn't feel like walking now or running, as he's not comfortable. And there is strain on the knee on walking, especially running. Hence, there is functional disability. Let us measure the amount of deformity in the frontal plane. In the frontal plane, as you can see, there is 12.8 degrees of tibia vera at the site of union. And perhaps there is some rotation of the tibia as well. This is the frontal plane, and in the sagittal plane, the PPT is 74 degrees. Normally it is 80 degrees, and there is procurvatum of the tibia of 8 degrees. I repeat, in the sagittal plane, there is 8 degree of procurvatum at the tibia, which can only be found if we analyze, if we draw the angles. So, if we clinically check FFD of the knee on standing,
टांग ढाल ऊपर, हाँ ऐसे। अब देख, ये मूवमेंट नहीं होगी बिल्कुल भी तेरी, ठीक है। जब आप इस पे जोर पाते हो तो इसकी जो है मूवमेंट हो रही है अच्छी खासी, ठीक है। अब इस पे पाओ, पाओ जोर, इस पे और जोर पाओ, हाँ ऐसे, और बिल्कुल ऐसे, ठीक है। इसकी मूवमेंट
on standing and bearing all the weight on the involved lower limb, which is right side, the patella does not move, which means the quadriceps is contracting. While on the normal side, if all the weight is borne, the patella can be very easily glided side to side. If the patella cannot be glided side to side, that means there is contraction of the quadriceps and the patella is tight. Indirectly, this shows there is FFD of the right knee. And on loading it, the quadriceps has to contract to stop the knee from buckling. This is a test for checking FFD of the knee. Radiologically, might not be that important sagittal plane as much as this test is important. So please underline if you find there is doubt whether FFD of the lower limb is there or not, by standing the patient on the involved lower limb, if the patella cannot be glided side to side and quadriceps is in contracted position, that means there is FFD of the knee. I chose Ilizarov and Hexapod. Why? And to tell you the truth, even patient chose me. I'll tell you how. He's a commando. He can get the surgery done anywhere without spending even a single penny because his treatment is free everywhere. He has to go through time and again for metal detector for security reason, and he does not want any metal inside, one thing. Second thing, he doesn't want any surgical intervention again for removal of the implant later on. So he preferred Ilizarov. He searched everything and then he came to. You see how the scenario is changing. A police commando who sustained the injury, who is searching the right appropriate treatment, he searched that Ilizarov will be a better method and some sort of correction with the hexapod rather than some implant inside. If some implant is inserted inside, like nail or plate, he will not have to spend any single amount of money. But here he has to spend a lot of money, but he choose Ilizarov and Hexapod. So there is a place where someone will really find out that who is the Ilizarov surgeon and who can give him the best. So this is what we did. We applied Ilizarov and Hexapod, corrected both the planes, frontal as well as sagittal. Both the deformities, they were corrected, and he was functional in this hexapod frame. And let us listen to what he says.
तो ट्रेनिंग खत्म होते मेरे को ये हड्डी मुड़ी मुड़ी हुई जैसी लगी था और जब रनिंग करता था तो ये पैर अंदर की तरफ जाता था और इससे मेरी नी में भी दिक्कत आ गई थी, चलने में अटक जाती थी वो। अब सर के पास आया, फिर सर ने ऑपरेशन किया, 29 का ऑपरेशन हुआ। अब 30 को सर ने चला भी दिया मेरे को सारी मेरी प्रॉब्लम सॉल्व हो गई।
ऑपरेशन से पहले जब आप खड़े होते थे उस पे कितना लोड होता था, उस पे कितना लोड?
इस पे लोड नहीं था सर, इस पे सारा लोड इसी पे आता था।
इस वक्त उस पे कितना लोड है?
दोनों पे सेम लग रहा है।
ऑपरेशन से पहले वाली जो फ्रैक्चर हुआ था उससे पहले वाली पोजीशन आ गई
यस सर।
है।
यस
नंबर 2, आपका पैर अंदर को चला जाता था।
हाँ जी सर।
अब
तो ठीक है सर, बिल्कुल स्ट्रेट है।
आपका नी जॉइंट बाहर को घूम जाता था।
हाँ बिल्कुल सेम है सर।
आपका नी जॉइंट आगे आ जाता था।
अब ठीक है सर, अब ये लॉक नहीं होता सर, अब ये मूव करता है सर। पहले ये लॉक हो जाता था सर, पीछे जाता था तो लॉक हो जाता।
Patient understand each and everything, and you also have to dig out each and everything. Ask him, are these his problem? He will tell you. And you can see he's comfortable with the hexapod. His leg is correct. Whatsoever his problems they were there, they have been sorted out. This is the frontal plane, AP view. MPTA is 86.3 and PPTA is 78.4. Another big question is there, how much correction should be done? How much should be MPTA? There is range 85 to 90 and preferably 87. Let's look the normal side because we want to match it to the normal side. Whatsoever is the normal side, the PPTA, the MPTA should be the same. So we measure the normal side. In the normal side, MPTA is 83.5. Now the question is, should we make this also varus? The abnormal tibia should be made varus 83.5, or I have a chance now to correct it to the desired normal position. And what is the normal position? 87. But it's the range 85 degree to 90 degree. So you can correct it to 85 degree, 86, 87, 88, 90, anything. It is here the Ilizarov and Hexapod, the best tool. You can match the corrections with the function of the patient. How? We can keep on correcting till the patient sees his loading is getting better. So we titrate it. We start from 85, then 86, 87, 88, towards that. Patient will tell, yesterday it was less, now it's better. And then he will say, no. Yesterday was better, today it is not better. So we stop there. So this is functional matching. This is for that person. The tailor has to make the shirt according to the chest, shoulder, abdomen, size of the person. It is not a ready-made answer to each and every patient the same treatment. So you can titrate it. You can stop it and can go back as per the feedback of the patient. This is possible only and only with the help of Ilizarov and Hexapod. This is what we call dynamic functional feedback correction. Or dynamic correction, it is dynamic correction, which is with the help of a functional feedback from the patient. So again, coming to the same point, the deformities, they can be corrected acutely or gradually. Gradually corrections, big chunk, a small chunk, which can easily be treated acutely, and rest of that gradually. So 2 number and 3 number deformities. Here, the dynamic correction with functional feedback is possible. What is the need? Why should be so precise? I tell you, in certain situation, even 1 to 2 degrees of overcorrection or undercorrection can affect, enhance, or deteriorate the performance of the intended surgery. I again repeat it, even 1 to 2 degree of overcorrection or undercorrection, it can increase or decrease the performance of the surgery, especially in athletes, as well as in complex deformities of the lower limb, where at multiple locations, in different levels, different bones are affected. Multiple malalignment, malorientation syndrome, like polio. So this is known as dynamic correction with functional feedback, or dynamic functional feedback correction. And the carry-home message also is the sagittal plane is a very important parameter to evaluate the deformity of the lower limb. FFD of the knee is a disabling deformity and can lead to functional disability even if FFD is of 5 degree. Any fracture of the lower limb, femoral or tibial, can lead to FFD, fixed flexion deformity of the knee. The frontal plane issues might take years to appear, but the FFD, fixed flexion deformity issues, they disturb the gait immediately. टांग मुड़ी हुई है, इस पे कोई लोड नहीं है, सारा लोड इस पे है, और इसका ये पटेला बिल्कुल लूज है. अगर लोडिंग पे पटेला लूज है तो मीन्स कोई भी FFD नहीं. Is not. You see, this is the sagittal plane. The lion is so powerful, but in sagittal plane, you can see he cannot balance the body. There is hardly full extension of the hips. There is FFD of the knee. He needs support of a thin, lean person to stand, but still he cannot stand. So sagittal plane, my dear friends, is important. And it's important parameter, must be evaluated. And please allow me to end in a slightly lighter mode, so that people can remember what is FFD, what it creates, how it creates the problem. Carry home message is, in FFD knee, quadriceps muscle is always in contraction in stance phase, which leads to fatigue and functional disability. It can be called quadriceps stance phase priapism, which means it is in contraction. It will lead on to fatigue. It will lead on to functional disability. So thank you very much, dear friends. I think I have tried myself to justify dynamic corrections with functional feedback in this simple fracture of tibia, which in the past I think 40 years back, nobody could have thought of that it should be corrected. Very subtle amount of frontal and sagittal pain. But you see, the patient is smart. He knows he's having disability. He knows where to go. He knows what kind of treatment he should get. He knows no implant should be there. Thank you very much for your patient listening. Thank you.